as a doctor, as a dental surgeon, a nurse, a physiotherapist, a pharmacist, whatever kind of healthcare provider you are, what is your primary duty of care? In many countries, it is defined by law. But officially in India, here is the way it is defined. To mitigate suffering. If you forget everything, just remember this one thing. You have a primary responsibility to mitigate my suffering when I come to you as my patient. You have to try to improve my quality of life. Not only attend to the particular tumor or microbe or dental issue, you have to look after me. I hope that's accepted. Please note also the last sentence. There exists no exception to this rule. This patient, whose picture Radha has now seen about 73 times already, was from our waiting room a long time back. This man had cancer of the lung, which had spread to his bones. 6 weeks he was in agony. Out of that, the last 3 weeks, the family said he's hardly ever lying down. After hours in this position, he would roll over to a side and nap for 10 minutes. Then he's back to this. I understand that there are more than 80 participants at this session. 73 participants attending it today. Okay. At least some 20 people amongst you have had the experience, not necessarily of a pain like this, but grandparents, an uncle or aunt, or a parent going through a serious illness and with a lot of suffering. This man, in less than 1 hour, he saw a miracle. Lakshmi, I saw your eyebrows twitched. Lakshmi Prabhadas is among the 4 people visible on my screen now. I saw the expression on your face. And it's 5 rupees worth of medicine. Friends, let us accept responsibility as healthcare providers. This is what is happening in India to 96% or more of people in serious health-related suffering. We do all kinds of technological advances. We try all kinds of technological advances on them. We don't give them this. This is use of this medicine. He had morphine, something that was been recommended for this by World Health Organization in 1986, 38 years back. This does not happen in Euro-American countries. This is specific to us. And friends, I remind you, Anjita, Atmaja, everybody, I remind you, officially defined responsibility of the medical healthcare provider is to relieve suffering. This is not an optional extra. This is something that we have to do. We are supposed to do. Okay, I see that more than 30 amongst the audience today are dental surgeons, oral medicine specifically. One thing I would like you to remember, I am not like Radha, and Radha is not like Sridevi. Sridevi is not like Sangeet. We are all different people. Our, not only the physical appearance, but the way we are made is different. You may be a very strong person. That doesn't give me the responsibility to be as strong as you. I can be different. That's the way humans are made. If I am squeamish, if on the dental chair, I keep clenching my teeth and you have to work hard to work on me, Please understand, that's the way I am made. I don't have to be apologetic about it. We are all different. And sometimes I have heard a medical teacher of mine say this. For those who understand Malayalam, ഞാൻ രണ്ട് പ്രസവിച്ചതാ. എനിക്കറിയാം എത്രയൊക്കെ ഉണ്ടെന്ന്. കിടന്ന് ബസ്സൊന്നും ഉണ്ടാക്കണ്ട. I also have delivered 2 children. I know how much of pain can be there. Don't make too much of a fuss. That professor of mine is somebody from whom I a negative lesson. Not to be like that. So please remember this. So the duty of care is to mitigate suffering, prevention and treatment of serious health suffering, and improving quality of life. Unfortunately, friends, not only we don't do it, we are sometimes worsening the issue. See the numbers. Shaktivel Selvaraj and other friends published this in the British Medical Journal in 2018, showing that 55 million Indians, friends, that's more than 4% of our population, is driven below poverty line by catastrophic health expenditure. We are supposed to relieve suffering. What are we doing to them? I personally know of situations where the children go hungry. I'm still feeling very angry with that particular doctor who prescribed a multivitamin mineral expensive preparation, each tablet costing 68 rupees, to a poor man with advanced incurable cancer. And the poor man thought this was for his disease. And the family was going hungry. He had no income. Next time you pick up your pen to write a prescription, please remember, your prescription has the power to keep the children hungry that night. The numbers of people dying because of health-related suffering. 1/5 of all suicides in our country, according to the National Crime Records, which every year is 29,000, more than 29,000, are because of health-related suffering. I have been mourning about problems. I've been mourning about how pain is not treated and how we add to the suffering, etc. During your course this time, this is one ladder. 3-step ladder is something that you will get familiar with. I hope by the end of the course, you will be able to confidently and safely treat someone's pain. I'm not going into the details, but step 3 includes what's called a strong opioid. In our country, congratulations, easy for you. We only have to know 3 medicines. In Western countries, they have a medicine list of this long, but we don't have most of them in this country. I'm not complaining about that. That's okay. Keep it simple. Morphine, methadone. We'll briefly touch upon methadone. And fentanyl. Oh, Suma, don't have to madly make notes now. Those things are going to be dealt with in detail. There are going to be multiple sessions on pain management. It's okay. So these medicines are licensed. They cannot be available for everybody, but you, after this course, are empowered. In case there's that the criteria change from state to state, but in Kerala, online courses are adequate. This is what, with various adaptations, will be what you can practice in many pains. Non-opioids, because for the dental surgeons, I may be particularly sensitive to pain. I may shout, I may scream, mentally I may be weak. You do the miracle with me, with rational use of medicines. Everybody swallows paracetamol. Usually nobody knows the correct dose or correct frequency. That is too simple. We don't study it. We study complicated pathophysiology. Use of step 2, like tramadol. When to use it, when not to use it. None of these medicines is for everybody. So when you learn pain management, please remember this. And in your context, on the dental chair, or doctor, in the doctor's consultation room, in the oncology OP, everywhere, we may be able to adapt this ladder. Not adapt, use combinations of these things rationally. Let me bring out one more problem in our country. We'll talk more about it on another session of an end-of-life care. Hey, somebody read it for me. Why am I doing all the reading? Some volunteer, please unmute and read for me. Neeta, Ragesh, anybody volunteering? Unmute and read it out. Thank you, Ragesh.
In India, the poor die in misery of neglect. The middle class die in the misery of ignorance. The rich die in misery on ventilators. No one gets a pain-free and dignified death. Dr. Sankamitra.
Dr. Sangamitra is a British oncologist of Bengali origin who now works in Australia and does charity work in northeast of India. And he said this about end-of-life care in India. End-of-life care in India is notorious. In the so-called quality of death index, India comes among the worst 20%. This is something that you must learn in detail. There will be a session on end-of-life care where you will see that, as advised by international recommendations, healthcare system has to reach people where they are when they need it. It would have been stupid to wait for this man to get to the hospital. If this team from our team, this is Dr. Amina, if they had not gone to his home, he would have never been able to sit up like this. He would have been in misery for weeks before he eventually succumbed to death. But end-of-life care like this, that is an obscene violation of human rights. This is not the way people should die. But I'll skip that because we will go to that when we have another session but on end-of-life care. But I know there are oncologists there. Doctors, we will come to this in detail later. But this is what you recommend. National Cancer Grid, a collaborative of more than 300 organizations, together recommend do not treat patients with advanced metastatic cancer in the ICU unless there's an acutely reversible event. Well, those are some of the problems. Now, we will talk a little bit about what is this suffering that I am talking about. Is it only pain? Her problems are the pain and the breathlessness from her metastasis in the lung cancer, afoot of which she is unable to lie down. It's also her fear. How will I have to die without taking in a little bit of air? What is it like to die? The social issues. It's so many days since my husband has even visited after I came here. Is he going to desert me? What will happen to my 2 children? God, why did you do this to me? Why did God do this to me? I wish I were dead. The spiritual issues. All these are together bothering every one of those 7 to 10 millions of people in serious health-related suffering in the country. Please note that each circle is encroaching on the other. One of them will cause the other. We all know that somatopsychic problems and psychosomatic problems are both possible. Intense physical suffering will cause great emotional distress and vice versa. And together they will cause worsening of social relationships, poverty, and thought, why did God desert me? This is the concept of total pain. Hey, ladies and gentlemen, who founded the palliative? Who was the founder of palliative care movement globally? Hey, somebody unmute and tell me. One person who, the founder of palliative care movement globally.
So Dame Cecily Saunders.
Very good. Dame Cecily Saunders from in UK, who sadly died about 19 years back, who was a nurse, then became a social worker. And that's an interesting story. She went on talking about all this, and a senior doctor told her, Cecily, go and read medicine. Unless you are a doctor, no doctor will listen to you. So at the age of 29, she became a medical student and eventually qualified in her 30s. She is the founder of palliative care movement. And she brought up this image, this concept of total pain, where the person is converted to a mass of pain with no space for being human. And we are talking about 7 to 10 million people in the globe. Please note this phrase, serious health-related suffering, SHS. You will hear a lot. I'm sure Sangeet will share this presentation with you all. And in this slide, go to this reference for the Lancet Commission report. It's a long report, 60 pages or more. Just read the executive summary. That itself comes to 4 or 5 pages. Just read the executive summary. This is must read for you. Must read. I don't know. Sridevi, I don't know if you are there. And Radha, Sangeet, I don't know if this can be made the subject of one of the assignments. Is to make a sort of take-home points from the executive summary of the Lancet Commission report of 2017. This is free access paper. Just click on the link and you can read the article.
Sure, sir.
No.
Sure, sir.
Sorry?
No, I was just saying, sure, sir.
Okay, thank you, Sangeet. This concept of serious health-related suffering is something that you will have to develop and make your focal point. And at this point, ladies and gentlemen, let me remind you of one thing. What causes SHS in USA and what causes SHS here may be very different. There is a spinal injury and paraplegia in Europe. You see the woman or man on an electric wheelchair doing his or her own shopping in a supermarket in 4 months. Here, that person is incarcerated behind 4 walls forever, lifetime imprisonment, gradually worsening pressure sores, repeated infections, gradually worsening urinary infections, and dying a slow, painful death over many years. So let us go by our context. Not only going by the list of 20 diseases that you will see in this article, we will have to expand that list for our context. So friends, when I come to you, eventually, when my time comes, please do not just check the Lancet Commission report to see if my diagnosis qualifies. Dr. Prasila, Dr. Tanya, if I am suffering, please see me. Do the needful for me, irrespective of the diagnosis. This is the existing official WHO definition for palliative care. Very long. If somebody asks you, Hey, you know what is called an elevator pitch? You get into the lift and find a VIP on the lift. That person asks, hello. And you say, hello, I am so and so. What do you do? I'm a palliative care doctor. Palliative care, what is that? Before the lift reaches 32nd floor, you should be able to say what you do. If you want to do that, this is not the answer. Your answer is we treat suffering. We treat health-related suffering. But this long definition is the official one. See, it is 22 years old. High time this was amended, but that's the way it is. I have shown some parts of it in a different color. It's about improving quality of life of patients. Hey, ये point note किया जाए. It's about quality of life of patients and their families. The whole family suffers along with the patient. In any life-threatening illness, this is the term that has been criticized. Everybody has been asking WHO to change this phrase. The disease doesn't have to be life-threatening. If the suffering is serious, it has to be undertaken. So what you do is prevention and relief of suffering by treating pain, other physical problems like breathlessness or punctuating wounds or whatever, psychological problems, social problems, and spiritual problems. If anybody learns this by heart and is able to say this, I am not going to give you a gold medal. Just make a point of noting the prevention and relief of suffering. And note that it's also for the families. Angit, do you think you are ready with the poll? We had a communication gap, I know.
Yes, sir. Due to some technical issues, the poll is not being resolved.
Okay, doesn't matter. Hey, hello, what do you think? Sanjeev Berua, Victoria, Anup, Neeta, what would be your choice? Unmute and speak.
The time of
Sorry.
The time of diagnosis.
at the
Your voices were breaking.
When pain or suffering starts.
Oh, what a relief. Who said that? Please tell me your name.
Michael.
Michael, I will come to you for treatment. Thank you. You will not wait to see whether the disease is curable or not. You will not wait to see if I am dying or not. You will not even see whether my diagnosis has been made. If I am suffering, you will start my treatment. Thank you to everybody. I hope you will take that lesson. This is our duty of care to mitigate suffering. And when my suffering starts, that's the time to treat me. Actually, not exactly in that words, but WHO, in that official definition of 2002, adds some footnotes, and this is one of the footnotes. Hey, who is going to read it out for me? Volunteer, please.
Palliative care. Michael is reading.
Yes, please. Thank you,
Palliative care when applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications.
Okay. So, even in 2002, though they used the word life-threatening illness, they did say it is applicable early in the course of illness in conjunction with whatever treatment. Oncologists, You may be giving your chemotherapy. Go on. But do this along with this. You don't have to send the patient to a palliative care unit. If you have studied enough symptom control and psychosocial support, you do it. Actually, we, Sridevi and team, have done several courses for oncologists, pulmonologists, and so on. So that's also available. So you have to do this. Only when problems are difficult, they need to go to palliative care center. So we have been talking about pain. Now, I will just mention one other symptom. Let me get rid of the screen for a second and talk to you. So I am coming to you. I am coming to you with like that man with advanced incurable cancer, lung cancer, but not with agonizing pain, but with severe breathlessness. Only about 3/4 of all people with cancer have pain. 1/4 do not have. So that's not a criteria. If it is breathlessness and I am coming there unable even to breathe, where will you treat me? I am in the casualty. My oxygen saturation has dropped to 88% and it has been coming down. I am turning blue. Oh, where will you treat me? I've just presented myself in the casualty. I know what is likely to happen to me. I think before I know what's happening and before my family knows what's happening, my trolley is likely to be rushed into an ICU. And in about 10 minutes, a face will show itself through the door and say, his condition is bad. We need to put him on a ventilator. It will cost about this much. Michael, I saw you unmute. Did you want to say something? No. Please remember that it need not be. Because you are not trying to keep me alive for 2 more weeks. You're trying to relieve my comfort. It's not your duty to stretch out my dying process and my suffering for 2 more weeks on artificial life support. That's misery for me. So what you are supposed, what I do?
Preferably hospice or at home, the patient should get the treatment.
Thank you, Michael. But one thing, hospices are available to 0.01% of Indians who need it. At home, it's fine. Many people would like to be at home. Michael, provided you are able to give me support. Because at home, I'm unable to take breath. I'm suffering. So unless you have prepared me in advance and told me and my family, if he develops breathlessness, give this. If he develops pain, give this. Unless that preparation has been done, I can't stay there. So Michael, though I have told you, doctor, I want to be at home. But at 2 o'clock, I'll come to your hospital because I'm suffering so much. I will not take him to the ICU. There is no international protocol that all death has to be in the ICU. It's only in the protocols of Indian corporate hospitals that anybody with a saturation of less than 90 has to be in an ICU. Anybody with an sodium concentration of less than 128 has to be in an ICU. That is not the way it is. What I will do is, if that is what the person wants, instead of keeping the patient on ICU, I will keep the family by my side. That's very important for me. Surya, Lakshmi, Anjita, I want to be with my family. I want my son's hand to hold on to. And if you relieve my breathlessness, I may be able to say a final word of farewell to my wife. I may even ask for a final kiss from my grandchild. Dr. Atmaja, Dr. Thanya, Dr. Prasila. I know you have a lot of medical knowledge, but you cannot give me what they can give me. Any family member who wants to be there, I'll keep them there. What I reassure them is that everything is not going to be okay. Don't worry. That I will never, never, never say. Because the patient knows that he is not going to be everything is going to be okay for him or her. By saying, hey, will you please raise your hands? Whoever stops worrying because somebody tells you not to worry, pointless. Instead, I'll say, I see you are very breathless. One of us is going to stay here till we make you feel better. We will try our best to make you feel better. That's realistic reassurance. I do not necessarily give oxygen to everybody. It doesn't help everybody. Oxygen will help only if it will reach enough, will reach the lungs. If there is a severe obstruction, what's the point? So what I'll do is, I'll tell the person and family, I'm going to put this oxygen mask on. If it makes her feel better, I'll continue it. If the person is not feeling better at the end of 10 minutes, we'll take it away. Because friends, if the person feels better, he will ask for it. Otherwise, if the person doesn't feel better, it's suffocating. And it feels very hot under the mask. I'll take it away. I am actually telling you what I do. I may use corticosteroids, the vast majority of patients, whether it's cancer or COPD. And whether it is cancer or COPD, I would use morphine. Low doses, not 20 milligram 4 hourly, like for pain or whatever. 2.5 milligram 4 times a day is what I'll start. You will have more discussion on this. I am sure symptom control will be dealt with in detail. So please don't bother if all the points are not understood. The main point is you are not trying to prolong the dying process. You are trying to make me feel better. If that is so, as I said earlier, palliative care has to be integrated to Dr. Anjana's. Dr. Anjana, you are a dentist or MBBS doctor? Doesn't matter.
Sir,
Yes,
I'm
Anjana?
dentist.
Huh?
I'm dentist, sir.
A
Oral
dentist.
medicine.
Into your dental practice, into your oral medicine practice, you would follow this. The person is coming only for a dental work. Okay.
Okay.
The person may be still anxious. What you do to alleviate the suffering matters. What you do to relieve pain matters.
Yes.
We are talking about integrating palliative care into every healthcare provider's practice. The oncologist is very busy. I know. You in oral medicine also you may be very busy. You even within the time you have. Hey friends, there's time to hold their hands. Look the person in the eye. I will do it with as little suffering for you as possible. I'll try to make you as comfortable as possible. Be kind. Allow your muscles to relax. Don't let your degrees cause muscle rigidity and make you ferocious. Did you know that muscle rigidity increases with the number of degrees?
Yes.
I can prove it scientifically. So integrate palliative care into health systems at all levels, primary, secondary, and tertiary, across the continuum of care, from the beginning of the suffering to the end. This is the exhortation of 10-year-old World Health Assembly 2014. They are doing a review of progress this year. Unfortunately, most progress has been in developed countries. So, palliative care access to the masses in India or anywhere will be achieved mainly by the middle. integration of palliative care into your work. Whatever field of medicine you are in, whatever field of healthcare you are in, by integration of palliative care into your work. So friends, with this course, thank you for doing this course. This course, I have a better chance of getting compassionate healthcare. You may find that your basic knowledge is not enough to treat a difficult pain situation. By all means, send him to or her to a palliative care unit. But also remember, the community needs to come in to help us. You need to make the community aware, and this is an important part. I will not go into the details of this, but someday when you have a session about organizing palliative care, we will talk about how the community becomes relevant. The stage is set in India. So many positive things have happened. There is a national program for palliative care. The law governing opioids have been amended in 2014. Unfortunately, many states do not follow it. So if you find difficulties with this, please contact us. The National Health Policy of 2017 includes palliative care. It is there now. That's a remarkable change. But you know, in our country, the implementation gap can be huge. There's a lot of work to make sure that this gets implemented. And MBBS and nursing curricula, very recent development, now have palliative care. And Sridevi and her team are working hard to do faculty development programs. If all of you who are in teaching hospitals, please enroll yourself in the faculty development programs. If you go to palliumindia.org/training, you will have the information about all courses, and you can have empowerment to teach palliative care in your respective medical colleges. What the MBBS curriculum now includes is 20 modules of 12 themes. It's distributed from foundation course to internship under various departments. So Indian Medical Council and Indian Nursing Council have done it. National Medical Commission and Indian Nursing Council have done it. Friends, we still have to get it done by Indian Dental Council. And please note, there is a massive open online course which any professional can do, or a medical student also can do. And for MBBS faculty development, a trainer's guide, text and PowerPoint and videos are available, and faculty development course is available. And if you look at this website, you can have the details. Of course, you will hear more about it during the course. I'll stop there. I'll keep the presentation with me because so that if Radha, I see that time is 5:45. We have 15 minutes for the discussion. I deliberately finished faster today because there are 75 participants and there will be a lot of questions, I'm sure. Please, I'll take in the questions that I can see on the chat box. Ragesh, the terms palliative care and hospice care. Ragesh is asking what is hospice. The term hospice care and palliative care are often used synonymously, but hospices are generally placed institutions for end-of-life care. And this distinction was brought in by insurance companies in USA. Now the whole world seems to have accepted it. A palliative care unit is from the beginning of the suffering. A hospice is for end-of-life care.
Okay, sir. Got it, sir. Thank you.
Thank you.
Thank you very much. And as always, information from you and your way of expressing and reiterating what is important, what is that to be done, what is that not to be done. So, in anything, the important thing is that to know what you should do and what you should not do also. So, from that front, you have explained so clearly what is that they need to know. And as you mentioned, through this full 20 sessions, they're going to have in-depth information about pain, breathlessness. We have each symptom. So we have pain for 5 sessions, then each symptom about 10 sessions. And so they're going to have enough information on all those things. And it's going to be interactive. And they will be happy at the end of it, knowing what is that they need to know. So thank you very much. And all of you can ask what is that, like from what you've heard so far, you can unmute and ask what are the queries, because always better to ask all queries and doubts now. When you actually start seeing patients, you should not have any inhibition or anything. You should feel comfortable to render the best thing and alleviate suffering. That is the aim. So please feel free. You can unmute and ask or type in the chat box whatever queries that you would like to know.
Sir, I have a query, sir.
Yes, ma'am. Michael.
Please go
Sir,
ahead.
Sir, how to convey to the patient's family or to the patient that the patient is not getting benefited by giving oxygen? So we are shifting the patient to nasal prongs or without the oxygen. Because as soon as we remove the mask, the family gets apprehensive. The patient sometimes also starts thinking that we are stopping the treatment. So how should we proceed with that?
Michael, sorry, it's not Michael, Sudhi. Sudhi, thank you for the question. I have been calling you Michael for some time. So sorry for the misunderstanding. Sudhi, if you know the patient already, if you have been working with the patient, then it's easier. Your conversation starts early. If it's a person with lung cancer, or even if it's an intra-abdominal malignancy with pleural effusion happening, you can predict it. If breathlessness happens, this and this are these are the things to do. These are the things that you can do. These are the things we will do. Okay, but suppose Sudhi is in the casualty and a patient breathless who is very breathless is coming in at that point of time. You now, of course, in the emergency, you will check the oxygen saturation and find that it's dropping. And at that point of time, in the presence of the family, this is important. Don't drive them away. The presence of the family, tell them, we are going to put oxygen on to see if it will help. Now, I will also tell them that very often in this kind of situation, that is, if it is an advanced lung cancer where air is not reaching 2/3 of lung tissue, oxygen doesn't help because it doesn't get here. So if it is not helping, he may actually have some more difficulty in breathing. We need to take it away, open the window, and let him have a table fan against his face. He'll feel a lot better. So this explanation has to go in. Generally, it works unless there is a doctor or nurse in the family. They cannot accept it. For them, oxygen is divine. But suppose, okay, Sudhi, having said that, no, sir, please continue give oxygen. The other doctor has told me that he sent me here because he needs oxygen. Okay, in that case, give it. Unless the patient is keep taking it away, then you may explain it again. In this case, the fact that I have given oxygen for 10 minutes, he is not improving, shows that it is useless. And you can see it is troubling him. But suppose they are very much afraid, or if there is a medical person in the family, okay, maybe we'll continue it along with your other measures. I will not, I'll try to avoid, I'll try to fight the world to avoid intubating that person if it's advanced into incurable cancer. With oxygen, I may be more flexible. After all, the harm that it can do is only so much. Shruti, have I answered your question? You still have a question mark
Yes,
on
sir.
your face.
Yes, sir. No, sir. Yes, absolutely. I understood.
Okay, thank you.
I'll try to practice from the next time.
Okay,
Thank you, sir.
thank you.
Anybody else wants to ask anything? Please go ahead.
Hello, sir.
Yes.
Sir, what are the
Rajesh?
legal?
Okay.
Yes, sir.
What are you? What do you do?
Legal issues related to same end stage, and patient decides or to remove the mask, and something happens, but their relatives may be against the doctor. Right?
Oh, yes. This is not only about oxygen. This is about many things that we do. What are you, Dr. Raj AC?
Sir, I am from oral medicine and radiology
Okay.
faculty.
Okay. Now, nothing at all will ever protect you from litigation. Anybody can take you to court. What will protect you what will you be protected against is only conviction. Litigation is least if you have good relationships with the patients and family, if they trust you. As I said, if it is a question of oxygen, I will not be dogmatic about it. But Dr. Raj, you are absolutely right. These questions arise. The patient and the son agree. Then the daughter comes from Abu Dhabi or California and gets very angry. These things happen. One of the things that you will learn in our communication is how to communicate with the angry patient. Like there are many lessons there, but to that daughter, you will have to make the person sit down. And instead of arguing with them, what I would do is, I'll make the person sit down. That's very important, to get the person to sit down and say, you are angry because you love your dad so much. He has many problems, but I think he is lucky to have a loving daughter like you. You acknowledge the anger. You acknowledge the suffering. That's one way of jumping across the net and getting to her side. If you get angry, you have lost the game. Then you will meet in court. But Dr. Raj, it doesn't always work. I admit that. But you must also remember that in the field of palliative care, litigations have been minimal, very, very minimal so far. And that's because the relationship we build with the patient. But there's another point about it, Raj. If the person is at the end of life and you are not ventilating them, or before doing anything invasive, always get consents. You don't need consent for giving morphine. That's deemed consent. Medicines are given. But if you do any intervention, or if there is any doubt in the family regarding whether he should be taken to ICU and put on a ventilator, once they arrive at a decision, just make a note of it and get it signed. Informed consent is important. The original consent that you take at the time of admission in a printed form carries zero weight. This has to be specific to the matter and has to be written down.
Thank you, sir.
Thank you, Rai. Dr. Babu George, from your face, I suspect that you have a question. You have been wondering whether to ask it or not.
Uh, yes, sir. I'm actually indeed fortunate to have this session taken by you. I think back in 2018, I had my convocation and I had received my convocating degrees and all from you, sir.
Oh.
Sir, so my question is a bit controversial actually, and it's because I had several personal experiences on this regard. Sir, we are well aware of the fact that in Western
Oh,
countries,
your
especially
voice
US,
broke. Please repeat that sentence.
sir, with regard to Western countries and palliative care, sir, they have to, for example, in Western countries, they have this act called Death with Dignity Act, which permits assisted euthanasia in cases of terminally ill patient. I have also come across some one instances where my patient was very indifferent and would not accept to anything that has been told in a encouraging way. Uh, which I would, from my limited point of expertise, I could tell him. So, sir, what is your take on that aspect, sir? Would it be genuinely, if the some patients would be genuinely asking for such a termination, and just because it is their argument is just because it is possible in some parts of the country, some parts of the world, why not India is taking a stand on it? So, sir, I would like to know your opinion. Right.
Thank you, Babu. Babu, where do you work? What do you do?
I'm
Sorry?
an oral, sir.
Oral medicine. At the critical time, his voice breaks. Okay, doesn't matter. Look, there are some things that we'll have to accept. There can be a conflict between what you think ethical and what is legal. One thing is very clear. Dr. Sanjeev, Dr. Sunila, one thing is very clear. You will not do anything illegal. If something is against the law of the country, you cannot do it. We have to respect the law, no doubt about it. And in India, euthanasia is illegal. In India, euthanasia is murder. It is not even manslaughter, it's premeditated killing. After all, euthanasia is killing. In India, euthanasia is illegal, period. Finished. But is it fair? So many countries, as he says, have legalized euthanasia. Netherlands, Canada, many states in USA, Switzerland. Oh, Switzerland now has a euthanasia tourism. People are being driven across to euthanasia so that they can get assisted dying. So, why not India? Babu is asking me, why not India? I'll tell you, Babu and others, every single country which has legalized euthanasia, they have made a provision for palliative care. Radha kindly mentioned my time is up. Radha, just 2 minutes to complete the answer to this question. Radha earlier mentioned my book. In my book, Walk with the Weary, I have told you stories of people coming begging to be killed. Happens often. I remember once a man, I remember many people who came with the scars. I remember one man with cancer who was in such pain that he was striking against the wall and hitting his head against the wall. Blood splattered from his skull. And his wife was begging us, please kill him. Can't you see he is suffering? That man, after small bolus dose of fentanyl was given into his vein and then followed up with morphine, the next day sat up and had idli and sambar. So if somebody comes to me begging to be killed, as doctors, your duty and my duty is to relieve that suffering. And 9 out of 10 times, I'm not statistically correct saying that, 9 out of times, the request for euthanasia vanishes because they are actually begging for end of the suffering, not necessarily for death. But I'll also admit that there are others in whose case it may not be valid. So what should you do? If somebody is begging to be killed, find out why. Sit down there and ask. If you are asking to be killed, that means you have intolerable suffering. Tell me, what is it that bothering you most? They may most probably say a physical symptom, or they may say, I don't want to live. My own husband has deserted me. My children don't care for me. What's the point? You give them love. That is not in the textbook, I know. But Paracelsus many centuries back said the most fundamental principle of medicine is love. You make the person feel cared for. Say, nobody else in the world, you said, wants you. That's not true. We care for you. Tomorrow I could be in your position. We care for you. We'll do our best to make you comfortable. That would be our message. So, Babu, first make sure that palliative care is available to the majority of Indians, and then let us discuss the ethics of euthanasia. But it will be discussed. It is being discussed more than palliative care. That's the unfortunate part of it. But every country that legalizes euthanasia went through this period where it is discussed a lot, then it goes to the parliament. First time it is rejected. It goes again after 3 years, rejected. Then after 5 years, it is passed. Canada in 2018 passed 2 laws. The first law was to make palliative care a fundamental right. Second law was Euthanasia Act. Okay, Radha, sorry I exceeded time.
Not at all, because clarifying, and these are queries always, even when we do end of life care and explain about euthanasia, we say euthanasia is not passive, it is active, it should not be done. So these queries are always there, and many times people, like many myths still are there, like palliative care is only end of life care. So many things, hospice is palliative care. So all those have to be our effort, as you always keep telling. You have been telling that how many years of hard work of yours has helped all of us to at least come to a stage where we are at least openly able to talk and tell about palliative care. So always something from yourself to them will carry more value and weight. So thank you very much for giving them the best opportunity to have their course started with you. Thank you once again.
Yeah, I will stay on to listen to you with for the.
Yes, we'll go ahead with the
but in between, if
model
you have to
case.
go, you must excuse me.
No worries at all. We are going to do the model case presentation for them so that they will know what is essential, some basic things for that.
Okay.
Sangeet, can we go ahead with that?
Yes, yes.
Okay, like I will just welcome to all of you once again. You've all heard what is palliative care. The next what we're going to do is, in the structure of this course is going to be that every day you will have some topic being discussed, and then from our next session onwards, you will have an opportunity to bring up some cases. Why? For example, every symptom, you may be seeing patients, or you may even have like your friends, family with whom you might have treated someone with. So some case which is appropriate to the topic. That is the main and only requisite. So once you find some case appropriate to the topic, and keep it simple. So that's why we're going to just show you something. It is a model or template. Okay. You need to do something similar. Okay. Keep it simple. And at the same time, when you bring up these type of cases, it gives you first the opportunity to get rid of all queries that you could have. And it opens up discussion. See, for example, person A brings up one case. Person X or Y would have had this doubt same in their mind too. So it clarifies. See, the whole 80 of you have a platform where you can discuss openly. No inhibitions in this platform. Okay? If you're going to have inhibitions here, the day when you're going to see patients, that is not good at all, because that will bring down your morale. The confidence with which you see patients is what is going to gain your rapport with that patient. For example, in the discussion we had with Shruti, when one patient comes to A&E, if you have been seeing that patient for 5 years, so first thing, you will have confidence and full entire history about the patient you will know. And the patient will have confidence that this doctor whom I have been seeing knows me very well. He or she knows very well. She's going to do the best for me. So rapport, confidence, everything is covered in that. So use this platform, gain more information, and move forward. So feel confident when you see patients. More patients, more discussions, more comfortable you're going to be. And it'll make your life and job easy. Why should you struggle? See, all of us, see, medical profession is, as Dr. Ramaraj said, no, we are not the same. We are not the same. That also take it in a good way. Only if we are different, it is interesting. If everyone is same, that's boring. And next thing, if everyone is same, where is your expertise going to have a role? So many factors are there. So utilize everything. So we'll just see this case, and once I do the presentation, the sample one, then we can have some discussion on what are the queries that you would have when you are going to do them. Okay, Sangeet, can you get the presentation on, please? Thank you. We have got a patient who is a female patient, 85-year-old. See, name and things not essential. You can just mention first alphabet or X, Y, anything. Diagnosis is essential. Here we have got a patient with advanced COPD with acute infective exacerbation and also has systemic hypertension with type 2 diabetes mellitus also. Okay, and coronary artery disease. So next, that will be the main diagnosis, what you need to mention. Next will be presenting complaints. What are they? Breathlessness even at rest, unable to do personal activities of daily living. Then tiredness, sleeplessness, and loss of appetite. Sorry for the typo spelling error. Next slide, please. First, we gave about the symptoms. Next, little bit more. What is the history of illness? The patient has been suffering from diabetes, hypertension since 30 years. It started off as cough and breathlessness 20 years ago, took symptomatic treatment, found no relief, has had multiple hospital visits, and has been diagnosed with as COPD, chronic obstructive pulmonary disease. And another important thing, the next thing, patient has been having recurrent hospital visits with infections and has had 3 intensive care ICU admissions in the last 1 year. See, these are the essential salient points. So that is why whenever you give, no need to give again history which is not relevant, but give history which is relevant. So here, the initial history, what is there, history of illness, and the last point is very important. 3 intensive care unit admissions in the last 1 year. Okay, next slide, please. Then a little bit more about examination. Emaciated looking patient, oral cavity is dry, chest has bilateral creps, and cardiovascular status, heart sounds are heard. Abdominal examination, soft, no distension, bowel sounds are present, and also there is bilateral pitting pedal edema present. Next slide. Treatment. What treatment has the patient had so far? Patient has a poor drug compliance. She often stops medications when she has some relief. Multiple sessions done on need for drug compliance, but she's not willing to adhere to that. Currently, again, she's admitted to ICU receiving antibiotics and non-invasive ventilation, and they're planning for invasive ventilation. Next slide. Then comes, this is quite important. What are the psychosocial aspects? The patient basically is a homemaker living with son and daughter. Her husband expired 3 years ago, and her son is the breadwinner who is a coolie worker. And she also has some spiritual concerns, why God is punishing her. And see, the next line is important. She doesn't want to be hospitalized and she doesn't want to be ventilated. She just wants to be at home. Because already she has had experience, 3 admissions you have seen. So all these are important. So either the person or the patient and the doctor, they should have some conversation to know what is patient's wish, or not even one is wish, and what is that patient wants to say, and what is her most important feeling, or what is that it's her most important complaint or the most bothering thing. So that is what you have to ask. Yes, she has COPD, breathlessness, everything is there. But what is that she would love to express, and what is that she would like to get from the doctor? So those information you have to gather. If you don't gather, then ultimate management or goal cannot be achieved. Next slide, please. Then what are the treatment that she has obtained? She's had bronchodilators, beta-2 agonist, steroids, anticholinergics. Still, she's breathless. Okay, and she has had 3 intensive care admissions. She was ventilated for 4 days, but in spite of that ventilation, everything, she does not feel that she has had any improvement, and she's only scared. The outcome was that experience has caused more fear in her. Next slide. Now, that's why I said, what is that? This is the important thing. What is her main concern? Main concern is not her concern, and your concern also you can express in this. What is that? Main thing is that breathlessness is something, in spite of treatment, in spite of ICU admission, in spite of all those inhalers and everything, she's not getting relief. And next is recurrent admission and financial constraints. So these are the main concern from patient point of view and from your point of view also. Like, this is what you would have gained or obtained in the consultation time that you have had with the patient. Next slide. Next comes, this is important. Next we bring up something called as what are the important discussion points. See, here you put in your queries and doubts so that you will be able to bring forth your queries and have a discussion to get some outcomes and answers for it. Does she need palliative care? What are the components of her suffering, and how are we going to address it? Okay, so now what we will do, I think this is the last slide, Sangeet, am I right?
Yes, sir.
Okay, let us come out of it. So the main 3 points, I'll read this once again so that we'll have this in the discussion. Does she need palliative care? Then what are the suffering that she's having and how to address? Can you come out of this presentation, please? So that we will have a discussion with all of them. Okay, first thing what I'm going to ask all of you is this template and what you need to do, is that clear first? Because first, and also let me check the chat box if someone has had. Okay. So just the template. See, keep it simple. For example, as Dr. Sridevi was mentioning also, investigations and all, something relevant to it and relevant to the case. Okay, and also to what stage or what type of the symptom we are seeing. You do everything appropriate to that topic of presentation. Okay, and investigations, treatment options, all you will see what is essential. And coming into, like, when you go with each topic day, you will, all through these sessions, you're going to keep on gaining knowledge. Okay. So as we were telling, pain itself, you have sessions. Communication, you will have entirely some sessions on communication. So as you keep on going, as Dr. Amara has replied also, no, regarding communication, because communication is a very, like, a backbone, and it is again a skill which can be developed. That is something very important, because the queries which came up, how am I going to tell the patient? It can, we will also teach you how to tell, what to tell, where to tell, when to tell. Okay, and how much to tell. You have to find out. It's just not like I'm going to just go vomit everything. When the patient is not in a mind frame to take everything, you just go vomit, it's of no use. So first, you have to make sure that the patient is comfortable. That's what this palliative care needs, compassion and care to be ahead of everything. So if someone, and put yourself in that, if I am in that position, will I take it like that? Or if I am treated like that, will I feel happy and comfortable? So all this we will go through. So it is a skill which can be developed, and you tell, and then how to tell, how much to tell, everything will be covered. Okay. So all that we will go through step by step. So from your point of view with the presentation, this is the basic template, how it has to be. So just as you've all replied that with the template, and I think everyone is okay with, that's what I saw in the chat box. Template for psychosocial issues and delirium scenarios. How will the template be different or additional? No, like basically you will, for example, if it is oral cancer, okay, it's an oral cancer. See, end of the day, see what is disease, what is illness. Disease is diabetes mellitus. Illness is all the issues which that disease causes in that person. So, for example, the queries were psychosocial issues. Just let us take up oral cancer itself. Oral cancer comes for some 40, 42-year-old, very young male person who is the breadwinner. His wife is a housewife. He has 2 young children, one studying in 5th standard, one child studying in 5th standard, another child is 4 years old. So what all psychosocial issues you will have? He can have everything on earth. So still he has oral CA. He has all this also. He is a human being. He has to live. He has to earn. He has to have treatment also. So whatever topic it is all inside this only. So you elaborate on what is at that point of time. And again, in today's session, you all saw the 4 circles, each circle going, each one circle separate. Social, for example, this oral cancer person, he is the same man who has to have treatment, and he is the same father who has to look after the children and husband for that wife. So you will follow the pattern and give, if it is a psychosocial issue, you will give a little bit more importance for that. And in the discussion, you will have to connect and see the concern and points of discussion. You will have to see how these two are connected and how can we solve it. Have I answered the query? What was there for with the psychosocial or delirium? See, not only delirium, it can be vomiting, constipation, any symptom you can take. That symptom is part of the whole diagnosis or issue or problem. So there it will be, for example, if it is delirium, it can be anyone who is having a disease. It could be due to very many causes. When you see or read about delirium, there are 10, 15 causes. Any one of them can cause it. So that particular person can have it because of that issue. But the symptom or delirium presenting problems how to manage, everything is going to be an entity on itself. So have I, Dr. Babu, I think, had asked that question, Babu George. Have I clarified your query? Okay.
Yes, ma'am. Yes, ma'am. Understood, ma'am. Thank you.
Thank you. No worries. So, because better to ask, and as you all keep sending, no, I've seen you're all picking up the slots and taking stuff. So as you send, our team will decide the most appropriate case for the day, and we will go ahead with that. Okay, coming to this discussion, what we saw, no, the case that we presented today, does the patient need palliative care? What's the opinion from all of you? Do you all think that she needs? Yes, Anjana is responding. Yes. Open. Can we have open? Let me see what is the. Can we have open-ended? Like we don't know how to proceed in our case. Yes. See, as I said, this is a platform where, as the discussion point is that it's an open-ended one. Even in this, what are we asking? Does she need? What can be done? How can we solve? So that is what we are going to do. It's going to be that's why I say more case discussions is what will help all of you. Don't be hesitant. Bring up cases where you have concern and queries. So it will help all of you to open up, know more things. So those type of queries only can be dealt, and you will get answers. And another thing, see, now you may have more queries as you go along and listen to all these presentations. You yourself, even for example, you make up a case for that day, and you're going to do it after the case presentation, after the faculty presentation. So you yourself will know the answers. So many times it happens like that. Okay. And another thing is that ethics, like why, when, how, what are the pillars, everything you will be covered. Okay. So then you will know more about it. And then, for example, in this case itself, this recurrent ICU admissions and all, there are so much of information you will know how a patient like progresses from the time of diagnosis through their disease, and all those markers, this 3 times ICU admission, everything you will learn and get more information on all these things. Every time the patient gets admitted and comes out, what happens? Is the patient same as the patient went into hospital that time? Everything will be clearly explained by the faculty, and with crystal clear, simple pictorial representations. What happens? How does the performance status change? How is the progression of the disease reflected? See, few things in this case that you saw, in spite of getting 3-4 inhalers, the patient is not getting any relief out of that breathlessness. So what does that show? What does that show? Anyone wants to unmute and say?
And she herself has decided, no, ma'am, that she doesn't want to be in ventilator. Personally itself, with the psychosocial aspects, she has well understood about her sickness and the prognosis of the sickness. So it's better to go ahead with palliative care.
Exactly. That is her wish. That is one of the pillars of ethics. So her wish, and then she has experience. What that ICU only caused her more fear. So as we were telling in the discussion with the oxygen also, you have to, first thing is that we have to understand about the disease. And in this, being in the profession with experience, you know what happens as the disease progresses. You are doing a clear medical decision there. So disease progression and her symptomatic relief she has not got, and then you give the outcome for her, then make some goals of treatment. So all that you will see, and then respecting her wish is very, very important. So all that. So that is what you will gain and gather. I'm just reading through the chat in any queries so that we don't miss. Our concern is breathlessness, past experience, and financial background. Exactly. So see, that is where all the 4 components: physical, social, psychological, psychosocial, spiritual, everything you put into it. And next one important thing I would like to add on is always a multidisciplinary approach. You will see all that as you go through. A multidisciplinary approach and a multimodal management. So we will treat her pain. We will try to solve the psychosocial issues. We will try to do as much as possible from the social point of view, financial, and also spiritual. Nothing is left unlooked. Everything has to be taken care of. Only then you're giving total care. Otherwise, partial care. 25, if you give 25%, if you're looking into the 25% of the problem, is that going to be good? No. All 4 corners have to be touched, and all 4 corners have to be had some solutions also to see how you can cover everything and give them the best. So what that I think that social issues all covered. Their patients need reassurance, yes, and should feel less burdened for the family. Yes, definitely. That's why spending some time with them is very, very important. And going through what treatment they've had, what is the response. So when you explain all this to them, no one is going to fight or argue or go into legal levels with that. Only when things are not explained. And one more thing I wanted to add on is documentation. You have to explain. You have to explain and make sure that they have understood. Many times you have to ask the patient to tell back in simple words. All of us have the same knowledge and everything. Only having the time and patience is very important. So if you do all that properly, nowhere you're going to have litigation and things. So we have to make sure everything is done correctly and documented correctly. With whom you speak, with whom you have explained, to whom you told everything. So that, okay, one person comes, like for example, son is there. You tell, document, right? And make sure that that son conveys it to the rest of the family. Okay, so all these things are important. You convey and document, and then no one is going to argue, or you're not going to go into the wrong books of anyone. Okay, anxiety can exaggerate breathlessness. Yes, so that also can and should be taken care of. If the patient has not mentioned his wish and not in a state to communicate, what will the family do? Many times they go through guilt, how to address the situation. Okay, see, from this point of view, what Dr. Maithili has asked is, like, normally this has to be done by the parent or the caring physician. So when someone is not doing well or something, they can ask. And now here they've said that if a patient has not mentioned wish or something, then the next of kin. See, whatever we say as patient's wish, the same method of procedure we will do with if the next of kin, that is maybe the son or daughter or whoever it is. Many times it may be a friend also. And always everything is done in patient's best interest. What is that will be the best for the patient. So that is how it has to be done. And this guilt thing, no, we have to mention that it is a medical decision. That is where medical expertise comes in a kind and nice way, not in a hierarchical way. I know everything, I am telling. It's not that way. You have to, that is where you sit and talk to the patient and tell them, in this condition, in this worse breathlessness, or in this situation, in spite of everything, when there is no improvement. So you're not making any decision overnight or immediately. You always see that is why the person who is seeing the patient regularly has a better role. But if that is not possible also, you have to get in touch with whom has been the regular doctor, and then move forward from that front. So, and always in patient's best interest, the decision has to be done. And explanation is given to the next of family or the next of kin and telling them what exactly from medical point of view. For someone, example, has this itself you can take end stage COPD. You saw 3 times admission. Every time she herself explained that ventilation. So what will happen is every time their stage of the illness is getting worse and their performance will be going down. When you do your session of end of life care, there is a specific graphical representation for that, which you will be shown. So which will tell that every time admission, for example, they might have walked into the hospital that time. When they came out, they needed a wheelchair. After that, they have not been able to walk at all. Mobility reduced. Walking without support became walking with support only. So that is reduction in their performance. So like that, so many clear-cut indicators will be there. They are called as prognosticators, which you can see and explain to the family and explain. And then this guilt thing is it's a medical decision, and those explanations have to be done to make sure that they don't feel that. Hope I've explained in detail to what your query was. Yes, Maithili has answered. Okay. So anybody else has any other queries? Review, like see, as end of life care, you will have an entire session on it, and communication. Both together will tell you how to address these issues and how you go. See, that's what that in this, no, I think it is Dr. Nita Willi, no. So basically, there are ways. These all will be taught for you in communication. What type of question you should ask, what type of question you should not ask. So communication itself is done for 2 sessions, which will cover in great depth about it, because that is very, very important. That's why, the do's and don'ts, which will help you how to ask, and if the way you ask, you will get the best and correct answer. Okay, and I'm not going to spoil the whole, every beauty and nicety of all sessions in first day itself. Because you've got so many things to, every session is going to be interesting for all of you. Okay, Sangeet, in that case, I will hand it over to you. Thank you very much, Dr. M.R. Rajagopal sir, for being with us today and taking us through.
Thank you, ma'am. Dr. Rajagopal sir, would you like to say anything, a few words before ending the session? You're muted, sir.
Again, sorry. As Sadhira had mentioned that anxiety can exaggerate breathlessness, etc. Just to wind up with this story, I had once a visiting physiotherapist from another country in our team. And I had gone visiting this man who was breathless at home. As I sat down and started talking, the physiotherapist went behind her, and gently started massaging the back of her shoulder. Gently. I could visibly see the man's breathing becoming easy. Absolutely. When you are anxious, you try to breathe harder. And if you go back to your physiology days, you know that the harder you try, the more the airways collapse because of increased negative pressure. And the more you teach easy breathing, things improve. So, yes, absolutely. Okay, thank you, Radha. That was good to take everybody through the process. Excellent. Okay.
Thank you, sir. Thank you for the wonderful session. Thank you, Radha ma'am, for facilitating the entire session. Thank you all participants for joining. I hope you have a wonderful experience in these sessions. Thank you. Let's see in the coming sessions. Bye. Thank you, sir. Bye.
Thank you to one and all.